What's your name? Good afternoon, all. Our permanent secretary, Mrs. Naomi Jeremiah, permanent secretary within the Ministry of Mental Health, Wellness, and Religious Affairs. Mr. Josh Hector, our Director of Mental Health and Substance Abuse. Our PAHO country representative, Mr. Ronald Hewitt. Dr. Terrelyn Malcolm, I believe she is online. She is our advisor with PAHO on non-communicable diseases. Our facilitators for this evening event, Dr. Sumatra and Jasmine from PAHO. These are our consultants who have been working with us on our mental health policies. Representative from the Royal Grenada Police Force, the most important men and women in the land. We are so happy that you are able to join us this afternoon. And prisons, my apologies, and the prisons. Okay, thank you so very much. But all of you, men and women of the law, on behalf of the Ministry of Mental Health, Wellness, and Religious Affairs, we extend warm greetings to you for agreeing to participate in this evening's most important strategic step for the Ministry of Mental Health, which is our stakeholders consultation on our mental health policy and suicide action plan. We are really, really happy to have you with us. And we know that improving mental health and well-being is not only a health matter or health issue, but really it is a social issue. It is an economic issue. And really it is a priority for human development. Because we know when we are affected mentally, when you're mentally drained at work, can you function? When you go home, you're tired all over. You can't even exercise. Sometimes you don't even want to eat. You just want to go to bed. So when you have your mental, or emotions are affected, it can really disturb our entire society. And this is why we have you, the law keepers, really here with us today. So in order for us to be able to go into this evening's activity, we are going to ask the pastor among us. I believe I saw, what do you call this gentleman in the police? Eh? Trevor. All right. So we're going to ask Trevor to lead us in prayer. So can we all stand?
Could we bow our heads? Almighty and loving Father, we are thankful to you for the blessings of life, health, and strength. We thank you that we are able to contribute in one way or the other to maintain health, to advance health, and indeed to help those who might be struggling. We thank you for such a consultation where we are going to engage our minds and in fact depend upon you for wisdom and leadership by the Holy Spirit to navigate through this process so that at the end of it, it would benefit those to whom it is intended. We pray your blessings upon the facilitators. We thank you for the Ministry of Health. We thank you for the insight, foresight, and indeed the wisdom to be able to do this, which is so important. As law enforcement officers, prepare our minds and our hearts so that we be receptive to the information that we'll share and that we share our knowledge, our skills, our experiences, so that at the end of the day, it will be beneficial to all and sundry. We ask it through Jesus Christ, our Lord. Amen.
Thank you so much, Pastor. All right. So we're moving along, and we now call to the podium our prominent secretary, who would welcome you to this event.
A pleasant good afternoon to everyone. Today we at the ministry are happy to welcome you here. I feel happy to note the good turnout we have for this consultation. As you know, we value your discussion, we value your dialogue. I'd like to welcome with me our team at the ministry. We have Director of Mental Health, Mr. Josh Hector. We also have with us our mental health team that been working with our policy and action plan. We have Ms. Jasmine and Dr. Samantha from POWER. Online we have Dr. Malcolm. We welcome them also. We welcome the media. I'm happy to see a broadside of the RGPF here today. I am very happy to have you all. I want you to know that whatever discussion here will go a long way to help our completion of this most needed mental health policy, suicide prevention policy and action plan. As you see, our statistics with suicide is very, I don't know what to say, but it seems to be rising, and we need to move with a little bit of speed to ensure that we can really reach the persons who are targeted, the persons who have suicide ideation, and all persons who are affected with mental issues. And we want to be able to do away with discrimination and the set of treatment that we give to the mentally ill. I'm grateful for your input here today. What you're saying will go a long way to help draft and shape the final document that will be sent to Cabinet. Your input here is also will be taken into consideration, and don't feel whatever you say. Sometimes the minute points that you make can have implication for the policy. So that's why you are here today. We want to hear from you. We want to hear what your discussions, what your thoughts are. Our consultants from India, they are both here, and they are the drivers together with the ministry on this whole policy development. When everything is finalized here today, we are going to put the document within a cabinet submissions template, send it to cabinet. When cabinet approves this document, it will go to the drafting body. As you know, we have all laws. The Mental Health Act is over 100 years old, and it has outlived its time. A lot have changed since then, and we need to bring it up to par to this 20th century. So we have things like lunatic being describing persons who are mentally ill, which that dragon, the consultant will show you the changes that will be implicated. We also know that persons who are mentally ill at times, they are the whims and fancies of their relatives, because they are the ones who drop them by us and they go. And at the end of the day, they go with the house and the money's in the bank and everything else goes back to the relative. And we don't see them sometime after decades, 10, 20 years after. So we are here to protect them. We are here to show their interests and to show that they are being treated fairly and the decisions that are taken for their holistic care. You know, long time when persons commit suicide is on the book. Cap 223 of the revised act of the revised laws of Grenada gives you the authority that persons who attempt suicide, they can be arrested and charged. But however, because of your good wisdom, this policy will more have implications for care. So instead of having them arrested, we are going to provide care. These persons need counseling, they need care, they need to have a proper referral pathway. On the 22nd, that week of June 2026, we are also going to launch the Suicide Prevention Hotline. We have worked seriously with the SGU, the St. George's University, to have a response mechanism. So persons who is going to be a one-stop response, and then they will have referral pathways. Persons who you know, who we can refer. So we have a team of Quadri. You'll be hearing about that in the news. This is a plus for our ministry because we think the time have come when we need to launch that hotline. A lot is happening in Grenada, and we need to provide a response. So thank you for coming. May you enjoy the session.
Thank you, P.S. Jeremiah. I think you said it well. And to give us an overview of why we are here, so that at the end of this session we can meet our objective, we ask Mr. Josh Hector, Director of Mental Health, to do so.
Thank you, Ms. St. Paul, and good afternoon, everyone. Permit me to observe the protocol already established. And I simply want to provide a brief overview of what this policy seeks to achieve and why it is important to us all, particularly including law enforcement. The mental health policy is intended to serve as a national framework to guide how Grenada promotes mental health, prevents mental illnesses, expands access to care, and responds to mental health crises across the country. Importantly, the policy moves mental health beyond the walls of the psychiatric hospital. Let me repeat that one more time. The policy moves mental health beyond the walls of the psychiatric hospital and places greater emphasis on community-based care. Early intervention, prevention, and integration into primary care services. One of the major directions within the policy is strengthening mental health services at the community level so that individuals can receive support earlier, closer to where they live, work, and function. The policy also recognizes that mental health is not solely a health issue. It is interconnected with social issues, family well-being, substance use, violence, trauma, education, employment, and public safety. This is one of the reasons why the involvement of the Royal Grenada Police Force is so critical. Police officers are often among the first responders when individuals are experiencing mental health crises, suicidal behavior, emotional distress, or substance-related incidents. As such, your experiences, your perspectives, your recommendations, they are all extremely valuable in helping shape the practical and realistic policies and response systems. Today, this consultation is therefore important. We want to ensure that the policy reflects the reality on the ground and supports the work of all sectors that interact with mental health issues. We recognize that officers themselves are also exposed to significant stress, trauma, and emotional pressures in the course of duty. Therefore, conversations around mental health must also include the well-being and support systems available to the first responders. So we encourage open dialogue. I must say that so far, and the team can chorus what I'm saying here, is that we've had the most lively discussions from police officers. You were supposed to get a little lively at that. Right. We've had the most lively discussions from police officers, and so we anticipate that we will have a very lively discussion today. Thank you for being here, and we look forward to your participation in the development of this policy.
Thank you, Director. I believe the police is one of mental health key and very, very important stakeholders. And when I say police, I mean prisons as well. Because without you, sometimes we cannot get what we need to get done. And working as a community health nurse in St. Patrick, I must big up St. Patrick's. Where's the St. Patrick's people? And the workers from the police officers that man St. Patrick's. Nobody here? Okay. They do a wonderful, wonderful, wonderful job with the mental patients up there in St. Patrick's. They even give us a day in the week to use transport and go out and find them and make sure that they are taken care of. So we cannot do without you. So thanks again. I would now call our PAHO representative to do some brief remarks.
Thank you very much, Nurse St. Paul. Good afternoon, everyone. Allow me to adopt the protocol already established. It is my pleasure on behalf of the Pan American Health Organization to participate in this important stakeholder consultation on Grenada's mental health and suicide prevention policy and the draft mental health bill. I wish to commend the Ministry of Mental Health, Wellness and Religious Affairs for its leadership and for intentionally engaging police and prison officers as critical partners in this process. I also bring greetings on behalf of Dr. Amalia Del Rego, PAHO WHO representative for Barbados and the Eastern Caribbean countries, and Dr. Taradine Malcolm, advisor for NCDs and mental health for Barbados and the Eastern Caribbean countries. Both send their commendations and wishes for a successful consultation. PAHO commends Grenada's commitment to strengthening its mental health system through policy and legislative reform. Across the Caribbean and the wider region of the Americas, countries recognize that mental health, public safety, and justice are deeply interconnected. Modern mental health laws must support not only health systems, but also those on the front lines who respond daily to persons in crisis. Police officers and prison officers are often the first responders to mental health emergencies and are frequently required to manage individuals experiencing acute distress, substance use, or suicidal behavior, sometimes in complex high-risk environments. Your role is therefore central to this success if any mental health or suicide prevention policy or strategy is to be successful. This consultation acknowledges that effective mental health policy cannot be developed in isolation from the justice and security sectors. Grenada's unique institutional arrangement, having both a mental health and a dedicated Ministry of Mental Health, Wellness and Religious Affairs, that creates a strong foundation for collaboration. However, policies and legislations can only be effective if they are informed by your operational realities, safety concern, training needs, and institutional responsibilities. Your perspectives are essential to shaping approaches that promote early identification, safe and appropriate responses, diversions where possible, including continuity of care and protection of human rights, both for persons with mental health conditions and for officers entrusted with their care and supervision. PAHO remains firmly committed to supporting Grenada in advancing mental health reform and reduces avoidable harm, strengthens suicide prevention, and equips police and prison officers in the system to respond effectively, safely, and humanely. This afternoon, we look forward to continued collaboration as Grenada moves forward in this consultation to action, and we commend the ministry for its clear vision and inclusive approach. Thank you, and we look forward to a robust discussion.
Thank you, Mr. Hewitt. Before we go on to our presenters, I just want to inform you that on Wednesday, 3rd June 2026, at 6:30 p.m. to 8:30 p.m. at the Luke Cinema, Grenville, the Ministry of Mental Health and Wellness will be having its public stakeholders consultation. So please share the information around, advise persons to come out and share their concerns, recommendations, suggestions, all in an effort to enhance the mental health policy. St. George's, we will be having it on the 5th of June, same time, Agape Ministries, that is at River Road. So please share the information and help us to spread the word so we can get persons to participate so that when we finalize the policy, it would be what needs to be done for all. So I know by now you might be a little bit boring hearing everyone talk and talk and talk, but this policy is really, really important. It is really the gateway for us at mental health. It is the beginning also for us to be able to provide well-being care for our nation. So we are really serious about this policy. So we are asking of you to share your recommendations, your suggestions, your opinion, critique the policy if you have to, but help us to be able to, at the end of this, to be able to have a comprehensive policy that can really provide well-being care for our nation. So we call now to the podium Jasmine, who would lead the presentation, and then we're going to discussion. Thank you again.
Hi, afternoon, everyone. Okay, we've been tasked to do some more talking, so it's going to be slightly boring till I can finish my presentation. But I think the idea essentially is to share an update of how far we have reached with the policy level conversations, the consultations that we have done. And Samitra and I have been privileged enough to come and speak to some of the stakeholders and attend the last online consultations that had also happened. So what we will do for now is just walk you through how much progress we've made with the policy, what is already there. But you'll notice something curious about the policy, and I'll ask you that at the end of the presentation. So yeah, it's going to be, I'll just walk you through it, and then we open it up for conversations, discussions, feedback. As has been already clear that mental health is a priority for Grenada, and part of this work is stemming from a commitment to say that we care about mental health and we want to address suicide as an issue in our country. And we also understand that there's stigma and discrimination when it comes to mental health. So part of this policy and plan and legislative changes are a commitment to say that we're willing to reform the older systems, get up to speed with the international conventions, including the rights of persons with disabilities. A lot of the work has been anchored, of course, with the Ministry of Mental Health, but we've also been doing several consultations across ministries to understand what more we could do. Broadly, the purpose of the policy and plan is to say, how do we improve access to and how do we improve quality of mental health care for all of us living in Grenada? The focus is on promotion and prevention of mental health conditions as much as it's about the actual treatment response. A lot of the anchor points within the policy are looking at rights-based approaches, holistic, integrated, and non-discriminatory approaches. The scope of the policy and plan will span all across the programs that are being run by the Ministry of Mental Health and any other ministry looking at a mental health response. Very broadly, the vision is how do we create a space where mental health is valued, it's promoted, it's protected, and that people who have mental illness or who have a mental health condition can live on an equal basis with everyone else. So the focus you will see in the policy is moving away from just a clinical response to actually community-based integrated responses. Very broadly, the policy statement is picking up from what already exists. There is a national strategic plan which is looking at creating healthier Grenada and healthier populations, which includes mental health. So the entire policy is framed at an entire life course approach rather than just looking at people who need care, but the entire spectrum, like I think someone said it yesterday, from womb to tomb. So how do we create community-based, integrated, rights-based approaches? How do we engage people who have mental health conditions or people with mental illnesses as part of this policy? And encourage a space where there's advocacy and civil society involvement. There are 5 strategic areas that have emerged so far based on our conversations. The first one is looking at the anchoring of the policy, so the governance and leadership structures that need to provide a stewardship for implementing the policy as well as the plan. The second one is looking at building community-based resources for mental health response, which is integrated with the healthcare services, and essentially providing people care at their community level rather than waiting for a standalone mental health hospital. The third bit is where I'd like your attention. These are just some illustrative examples of how we've now had conversations across ministries to say where can we collaborate and what actions we could do. The fourth one is looking at improving our data systems and how do we integrate it with the existing data system for general health facilities, as well as mental health indicators so that we can create better responses for mental health, understand our situation better. And the last bit is talking about the rights of people with mental illness themselves, because they're often quite marginalized, vulnerable. So what systems need to be put in place to make sure that they're feeling safe and secure and part of the community that we all live in. So the next part of the presentation is just breaking up the components of each of these priority areas. So I'll just run us through some bits that are there. The first one is looking at governance and leadership. I think some of you have probably attended this consultation before, know that there is also a reformed mental health legislation, which is again in line with the international standards of care and the CRPD, which is it's basically a convention that is talking about rights of persons with disabilities, which includes mental health conditions. There is, of course, a strong move to say that decriminalizing suicide is a priority for Grenada. So those are the 2 efforts that are already being put forth. I won't get into the expected outcomes as of now. The second bit within the governance is also to make sure that do we have adequate funding to make sure that the plan and policy can exist. Based on international standards, the minimum spend for mental health should be a 10% of the health budget. This does not include other ministerial budget allocation. But in essence, at least the overall health budget needs to be allocated for mental health to make sure all of these plans and policies can be implemented. There is a great focus to say, how do we involve people who already have mental health conditions or mental illness as part of the policy thinking, planning, but more than that, on an ongoing basis for monitoring and evaluation to make sure are we achieving the goals that we had set out to do. With that, I move to the next strategic area. Sorry, it takes a while to show up. The next one is looking mainly at the integrated approach. So you'll see a lot of the integration within the general health services at primary, secondary, tertiary care level. Within that, one of the strong recommendations that has come up from evidence and from a lot of good practice is to say that we need to move away from single hospitals, which are only for mental health conditions, which in our case is Monge. So the idea is that how do we move away from single psychiatric units and move them into the communities and provide this as part of general health care, rather than excluding them to just one space which is only for mental health. So as part of this phased reduction, as you can imagine, you need to do several steps to make sure that they can move away from a long stay facility back into their communities. It will not happen overnight, and there are many steps that will need to happen for this to be a successful venture. But in essence, the goal is moving away from a single tertiary hospital to community-based services, which will mean that services will need to be reorganized from the way we currently see them. So as part of that, one of the efforts is to say that the acute psychiatric ward, which originally used to anyway be at St. George's, should move back rather than sitting at Monge. And that inpatient and outpatient facilities should be available at all general health facilities across the districts, including Carrico. The second bit is looking more at primary care services. So what can health professionals be trained on using standardized evidence-based tools such as the MHCAP? So what kind of identification they can do, treatment that can be done at the primary level to make accurate referrals further on to secondary and tertiary services. The focus of the policy is quite clear that it says training by itself is not enough and people need to be mentored and supervised to actually do behavior change after the training, because just possessing the knowledge is not leading to change in practice. A strong area of focus is also on suicide prevention, so specific amount of training that can be done at each level across different departments to look at what are the tools that we can use for early identification and therefore prevent, say, people dying by suicide. I'll move us along to the next strategic area where this is speaking more about different ministries that need to get involved for an intersectoral response, because mental health by itself it's a cross-cutting issue, so it sits across our work and departments. So the next bit is looking at one of the stronger recommendations that came in was in the past there was a MHPSS, which is basically unfortunately become very disaster focused, but in essence looking at mental health and psychosocial support. There used to be an interministerial committee that was formed, which could align with what was happening, how to create an integrated response so that there's no overlap and we're all leveraging each other's strength. So the recommendation that came in was different ministries need to probably be held together through a group and have ongoing meetings. The second one is looking mainly at social development ministry, and if they are anyway doing residential care, social housing. So how, if you're looking at downsizing the Monge facility, if residents need to move back into their communities, the effort is on community-based residential services that can be provided where people can get access to, say, social entitlements, disability benefits, so that they can exist in their own communities rather than in institutional care. There is a specific focus on people who are homeless, who do not have a house, and what kind of provisions need to be made, because for people with mental illness, often homelessness comes as an two-way sort of impact. The next bit is looking at education. So some of the work that is already being done is through life skills for children and adolescents. So how can the Ministry of Mental Health work with education to make sure that training is being provided, protocols are being created? And this again came up quite strongly, is to say that we should have a national mental health information campaign. So not just one-off event, but have a repository of information around mental health, engage in all sorts of mediums to make sure that people are aware of what are the myths around mental health, reduce stigma, and increase help-seeking behavior. The other collaborative bit of conversations we've had is with Ministry of Youth and Sports Affairs, where the recommendations were that if there are already coaches that work with young people, how can they be upskilled to do some gatekeeper, some first aid training, so that young people can get early access to care? And the other conversation is that there are many other field staff members who can also be trained to provide some mental health first aid support. The next strategic area is looking at more information systems. So again, like if we can collect good amount of data of what's happening in our country, our responses can be improved upon. So this part is looking at setting up a surveillance system to understand patterns of mental health use, of more specifically for suicide, where is it happening, what are the common factors for it, so that we can create an effective response. With that, I'll move to the last part of protecting rights of people with mental health conditions. There's been a strong focus to say that if we have signed on to these conventions, that people with mental illness are often a vulnerable and a marginalized group. Their rights are often violated. So what provisions need to be set in place to make sure that they can live and live in their communities, live at their homes, get access to the same rights like you and I do. And the last one that came up quite strongly within the context of Grenada was reducing abandonment by families because their relatives or their loved ones have a mental illness. So this is something that, of course, is quite a diverse and a multifaceted problem. And multiple things can be done to address this issue. But it's currently there because this has come up quite strongly that carers need support, families need support, so that we can reduce the abandonment by their families. The next part is looking mainly at compliances and next steps. In essence, how does the Ministry of Mental Health anchor the entire piece of work, make sure it's being reviewed, monitored, evaluated, so that we know we're on the right path. And with that, I'll close on the presentation. And you'll notice something curious that happened in the intersectoral collaboration. Does anyone know what happened? In the entire presentation, you didn't hear something. The hint is, why are you in the room today? So what you'll notice is part of the conversations have been with different ministries, and we've realized that there is a huge role for you all to play in this thinking around the mental health policy and plan, and what can we do collectively to make sure that your mental health care needs, as well as people that you work with, how can we improve the response better? Because this is an opportune moment to decide what will happen over the next few years, create some opportunities for change. So with that, I'll pause and I'll check if you have any comments, Samitra, before we open it up.
I think the comment was what you made, which is, there is nothing in the draft at the moment which mentions anything about law enforcement and the role of law enforcement in mental health policy. And so the conversation with you today is really to see how can we build in and what role can law enforcement play in mental health policy to achieve the goals of this mental health policy. Yeah, thank you.
Try to pass it.
So yeah, it's all open. I mean, please feel free to. Yeah.
Good afternoon, all. I have a few comments, but I'll be brief at it. The first one, the medication that is given to persons that have mental challenges. Can the medication be improved? Because from my recollection of conversations with persons who are on those kind of meds, the side effects is what they are afraid of. That's why a lot of them stay away from the medication. So most time after taking a dose of that medication, they don't want to return to take any more at any time. The side effects is a terrible problem. So can there be better medication for persons suffering from mental illness? Less side effects, or maybe more mild side effects, so they can tolerate it and they would take the medication. Next one. because we recognize that police officers are not specifically trained to deal with mentally ill or mentally challenged persons, can there be the formation of a mental health unit with persons trained and equipped to deal with such persons, so that when the call is made, that unit goes out and deal with the people, rather than exposing officers to the dangers of mentally ill persons? I mean, to give a background of that, 37 years ago, I have been dealing with those persons as a constable in the Central Police Station. 37 years after, the constables after me are still dealing with the same problem. Many persons got injured in the line of duty trying to control the situation where mentally ill persons are on the street and they would have threatened the lives of other people. Can we change that with a unit dedicated to deal with those issues? The other one, I agree with you that the acute unit should return to the general hospital. I am in full agreement with you. But while that is so, we have cases where persons must be confined. Some of them, they committed homicides and they must be confined. So while we may try to lessen the population at Mongi, we must have some persons confined. There are persons that are a danger to themselves and the public at large. If you release them into the public, somebody will be killed anytime. So we need to make the distinction, and there are persons that have to be confined. So we must know that. The last one, when we have instances of persons continually displaying hostility towards community persons and anyone, what can be done in those cases? Should we continue to allow them to be in the public so that they will endanger people's lives, or should we confine them? And if we can answer some of those questions, I do believe that we will do much better as a country as it relates to mental health and mentally challenged persons. Thank you.
Thank you for your questions and contributions, sir. Greatly appreciated. Now, just to speak on the medications, historically, when we only had first-generation drugs, the side effects were far more significant. To date, the drugs have actually been improved so that there are now some milder side effects. Notwithstanding, medications don't agree with everyone the same, all right? So it still remains important for open discourse between the patients and the doctors, because a patient does have the right to report, I'm having these issues, and if possible, right, if there's an alternative, then I want to believe that the doctors will provide an alternative. It would have been fantastic to have our psychiatrist here to speak. I mean, I could only give a surface response to that comment. But I can note for sure that the medications have improved significantly over the years. And perhaps if you pay attention to some of the side effects that you probably saw previously, you definitely notice a reduction in some of the side effects. For example, the stiff walk. You definitely, and I'm using that term loosely, but you're definitely seeing this a lot less. And that is because we do have improved medications, but that does not ultimately exclude the possibility of side effects.
Thank you so much, Mr. Hector. Now, with regards to the question that Officer in Charge at Immigration Department, in 2023-2024, Dr. Bohar, the psychiatric consultant, along with the team of medical experts at the hospital, reviewed our medication quadric, and we decided through the chief pharmacist, who we ordered through the OECS PPS, that we need to have a change of the medications, a lot of the medications that are being used then. We have since implemented that change, and right now Dr. Bohart will give a report as to what's the monitoring and evaluation of those new drugs which have been sourced through the OECS PPS, and that is being used now at the hospital. From that report, you're seeing anytime you have changes within the institutions that you must get reports and monitor. So we are at this monitoring stage now with the new drugs that are being implemented. So from then, the medical team will be able to ascertain whether we should reduce, withdraw, stop order, or order a new set. I think with the onset of Dr. Bohart, who was a professor at SGU, with psychiatric, and he looked at what we were using then and the implications, as you rightly stated, and the side effects. So now we are going to get that monitoring reports and then be able to take it from there as to what should be the next step. Yeah.
Yeah, thank you. I think a lot of your questions or comments just to me brings home to the importance for us to actually have a very large nationwide information and education campaign. So for example, I think the idea that medicines cause side effects is a misconception that a lot of our population has. What happens, the way I look at it is that if 100 people take the medicines, 90 people who get no side effects never complain about it, and they don't come and tell you that I was taking these medicines and nothing happened to me. It's the 10 who get the side effects who go around making all of the noise about the fact that medicines are causing a problem. You know what I mean? Like, this happens in every organization. If you put a complaint box, okay, if you're flying an airline, for example, you never ask them for a form to say, oh, I had great service, isn't it? The only time you ask for a form is to complain. You get what I mean? So if you look at feedback forms, they're only full of complaints, and you'll think, oh my God, everyone's complaining. The fact is that people who have a good experience don't bother to give feedback. Only the people who have a bad experience actually make the complaint. But the point I'm making is, as you heard from Dr. Hector, from Josh, and also from the PS, is lots of things have changed, but a lot of these beliefs that, medicines cause these side effects, everyone gets side effects, we should have better medicines. All of what you said exists. It's there. It is just that people still do not know that. So I think, so that's one part of misconceptions that need to be handled. What kind of treatment, medication, what are the side effects, how beneficial it is. The other misconception is around how we view people with mental illness. This universal belief that people with mental illness are dangerous and are going to attack people or kill people. Is again something that we need to really actively discourage or actively try and get rid of, because that is not the reality. If you look at the evidence, not just what people believe, but actually the evidence across countries, what we know is that people with mental illness are more frequently victims of crime, abandonment, abuse, all sorts of things. They're more likely to be victims of crime than perpetrators of crime. But what happens is that tiny minority of 2 or 3 or 5 people out of, say, every 100 who have a mental health problem, you equate the remaining 95 to that 5. I'm not trying to say that people with mental illness are not dangerous. They're as dangerous as anybody else in the community. You know what I mean? They're not any particularly more dangerous, nor are they any particularly less dangerous. but they're as dangerous as anybody else in our community is dangerous. And so a lot of these stereotypes that exist about people with mental illness need to really be addressed. And I think an educational campaign and an information campaign to squarely address these stereotypes is something that we need. The other point you made, which I think is very important, is you talked about a mental health unit which is trained to deal with within, I'm assuming in the police force, a unit which is trained to deal with people who may have a mental health problem. I would actually go beyond that. I would say that every police officer needs to be trained on how to deal with, because any police officer in the course of their duty is likely to come across someone with a mental health problem and how to deal with them. In fact, I'll give you an example from PAHO. In Belize, we designed, this was a request which came from the police force in Belize. So we actually designed an entire training manual on how police officers to understand mental health, as in when you see someone with a mental health problem, what should you expect? What should you look for, what you shouldn't say and what you should say, how to learn de-escalation techniques. There are ways to de-escalate a conversation with somebody who is very agitated, say because of mental illness. So we created this entire training manual and then trained the police officers. And the way we did it was we trained they had a police academy where they have police trainers, and we trained 40 of those trainers to deliver this training to the entire police force. So the point I'm making is that it is possible to train everybody in the police force how to deal with basic stuff, how to deal with if you come across somebody who has a mental health problem. And that's the kind of stuff that I think a collaboration between the Ministry of Mental Health and with the law enforcement agencies is probably the way forward for that. But countries in the region are already doing that, is my point. Places like Belize are already incorporating training of law enforcement personnel in how to handle people with mental health problems in the regular course of their duty, and to teach law enforcement personnel skills in how to deal with. There's no point in me telling you how to do it without teaching you actually the skill how to do it. I can say, you should use de-escalation techniques, but you need to learn how to do that de-escalation, because otherwise just telling you do de-escalation is not going to mean you're going to be able to do it. So I think we should be looking at those kind of trainings that are done to equip law enforcement personnel with the skills to be able to handle people effectively. And handling effectively means safely for everybody, safety for the officer themselves, safety for the person with mental illness, and safety for the general public at large. And I think that's the stuff that we can actually do training and teach people. You are identifying. Oh, there. Okay.
Good afternoon, all. I just want to join with Nurse Paul in the comments earlier on with the relationship with the police at the Sutton's police station and the nurses at the health center. We have a very good relationship, and many times we get a call. The nurses would accompany us to deal with persons with mentally challenged issues, especially Nurse Pierre. But there are some challenges that we face in regards to the long hours that we have to wait for the patient to be seen by a doctor. Sometimes there are no doctor at the complex, and we have to travel from Sutton's to Maribor or as far as St. George's. And in my opinion, it's a great challenge for us. And we don't have the adequate transportation to transport those persons from the north of the island to St. George's so that they can be attended to. I think if efforts or the emphasis is in place to have adequate transport or doctors at the health centers to deal with these persons at an adequate time, it will be much easier for us dealing with these persons.
I just wanted to address your response to what Superintendent Purcell said in relation to having a unit to deal with mentally ill people. I am not sure he was suggesting that the unit should be the police. You mentioned training for the police, but mentally ill is not a crime, it's a sickness. So why should the police have to deal with it and not a specific unit trained to deal with mentally ill people rather than the police?
Okay, let me clarify. I'm not suggesting. I totally agree with you that it shouldn't be the police dealing with it. I wasn't even suggesting that the police should deal with it. What I'm trying to tell you is that in the normal course of your duties, you will run across people who have a mental health problem. And even if there is a mental health, even if there is an ambulatory or a crisis unit which is going to come on the scene, you will still have to be talking to them or calming them down. What I'm trying to tell you is not that I didn't suggest, or I wasn't even trying to suggest that mental health problems should be dealt by the police. That wasn't my suggestion at all. Yes, so I'm saying training for the police officers, because frequently, let's say you run into someone who's homeless, okay, and they have a mental health problem. The way you talk to them and the way you handle them can either escalate the situation and it becomes a problem, or it can de-escalate the situation and not be a problem. And that's what I'm talking about training the police officers for. I'm not suggesting that the police officers start doing therapy for people who are mentally ill and on the streets. That's not what police officers are trained to do, and that's not what they should be trained to do. But to be able to, for example, to be able to identify, if you picked up some suspect for any crime, to be able to identify that could this person have a mental illness, okay? That's training which is useful to you.
I'm not suggesting that the police should not be trained.
Yeah.
I'm saying in the formation of the unit.
Right.
Mentally ill
So,
should not be the police.
yeah, so,
Police encounter them now because it's the only option you have. You don't have anybody else to call.
right. What would you give me an example? Like, give me an example when that happens, that police is the only option to call. I'll tell what I'm trying to tell you is that you probably get called when there is either a risk of or some actual threats and violence. I don't think you get called for every single mentally ill person. No, come on. Most people get, a lot of people turn up at the hospital on their own, they get treated, they come with their families. It can't be every single one, is all I'm trying to make my point. That you do get called, and I'm sure you get called when there are certain conditions which happen. And I'll tell you what the conditions would be. Is that A, the person is being violent and has a mental illness and is being violent, and so the family says, look, we can't handle this, we want to take him to hospital, but he's being violent, he's smashing up the place. You're likely to get called. Sorry? Yeah. So that's one time that you're likely to get called. The second time you're likely to get called is somebody who's, say, wandering in a locality and is clearly mentally disturbed, and the neighbors or someone will phone up and say, look, this person needs to be taken somewhere, call the police. That's another time you're likely to get called.
We get called to say, my son is talking to himself, he looks like he's getting sick again. Simple like that.
Yes, so what I'm saying is, when that happens, there is absolutely no reason why the police need to even respond.
Nobody else to respond.
No. There are ways. Well, Josh can tell you that there is a community mental health team in every parish, which not only goes out in the community to treat people, but also visits people at home and gives them their medicines if required. I mean, Josh can tell you a bit more about that.
So what we are trying to get from this consultation is the whole SOPs, because we want to have the standard operating procedure correct. There's something called the urgency order that is very important, and that is signed by the medical doctor. And we want to get the whole lineup of like how the officer said when they get a call, what happens next. And I think what we need to do at this point is really give them what the bill, the draft bill will say. It will create a bit of sense in terms of their role, how they should respond. Now they talk about a mental unit. Then where this mental unit will come into the bill and all of that. So I think maybe if we go a bit through what some of the proposed amendments to the bill, that will help and give them a better picture of how they will really interact when they encounter to certain situations. And situations can become very intense, and it can be life-threatening to them too, and they have to protect themselves. I noted before we had trained some persons how to react when you meet the violent, life-threatening persons who are mentally ill and they threaten even your life too, and how you respond. You know, sometimes you'll hear the police shoot the person and the person die, and everybody on the radio and they crying. Oh, I think we need to inform the public too of what the procedure is all about and when actions is needed to be taken, because nobody wants to just lose their life so at the hand of somebody with a cutlass and just killing, you know. We had a lot of history of what went before, but I think with the proper training and with the proper education, with the proper SOPs, maybe we as a ministry could develop a handbook and send it to the commissioner, to you, so you know, well, this is your handbook when you have that respond. Because sometimes officers move from one station to the other and they respond have to be differently based on the community and all of that. So if you have that handbook, that could help to know what is the operating procedure when you have this set of calls. But what at this point I think is important to give them an insight into the draft bill. Yeah, and we'll hear them out, and then
I think the point you made is I think PS just answered to that. I think it's important that there is a very clear procedure set out between the police and the mental health services, who responds when for what, and that everyone is aware of that. So for example, if you get a call like this, whom can you call up in the mental health unit and say, hey, you know what, this person, father is calling me up, the son needs treatment, somebody needs to go and address that.
I think more important than who respond is what you respond with, because the police are definitely not equipped to deal with mentally ill people. So we respond with guns.
I know, but what I'm suggesting is that the example that you gave me, that the father calls up and says that I've got a son who's not taking treatment, for example, or is likely to now relapse. What you need to know is that, fine, here is the community mental health team. This is the contact for them. I need to call them up and say, look, we had a call from the father. This person is not taking their treatment. You need to go and visit this person. And that's really has to be so that they can now take care of that.
Yeah, what I would want to say.
But that's my point. If they call the police, then if they call the police for assistance, that is different from asking the police to go and do it. There's a difference between saying, I'm going there, but I'm afraid there's going to be violence. I need the police to provide me with assistance. You see, so that's what I think what PS is talking about, is creating a clear standard operating procedure as to when there is. Yeah, I know, no, but what they're talking about is like they tell the nurses they won't go. So those kind of practical procedures for how to operate.
Yes, sir. I think I feel we have a misunderstanding along that. There are a few things that we need to consider. One, police officers are trained in a particular way. Correct. Now, we are trained in the use of deadly force. Correct. Deadly force could be used when your life or someone else's life is in imminent danger. And if you don't use that firearm, somebody could be seriously injured or killed. And that's why most of the times we use the firearm against mentally ill persons. So therefore we're saying that even though as it is now, police officers are the first choice because there is no other alternatives to the public. And that's why I'm proposing that there be a unit set up to be the priority call in place for the public so that they have somebody to call when they have their troubles. Now, remember, I was in this thing 37 years ago. We got a call from the Central Police Station to come to the Monge Hospital because Cholo refused to take his medication. And that wasn't the first time. The police has always been called because Cholo refused to take his medication. And that is how serious this thing is. So I am saying that there should be an alternative for the public other than the police, because the police will come with firearms and somebody will be hurt seriously. And we don't want to go down that road. I remember one night again, this man here could be a mute on that. We was called to Granton Road, just in the twilight. And there could have been serious injury there. The mentally ill woman was on the edge of her fence with half a scissors, waiting to drive it in one of the officers. Now we're saying that in the event that she drive, she would have been killed because we had guns. So the thing about it, we are not the first choice for that kind of work. No. If the person commit a serious crime, no.
I'm not saying this. I'm asking a serious question.
Because the other thing is, if we are called and we did not go, the public would hold us culpable for neglect of duty because there is no alternative to them.
I'm actually seriously asking a question that in that kind of example that you gave, who should be called is my genuine question.
The unit.
Sorry?
The unit, the trained unit.
The unit is who are these people?
Well, the law should set up that. The new enactment should set up such a unit.
I know.
No, what I'm saying, the unit.
That unit should be who? Who should they be?
The law would dictate that. The law would say who should be the director, who should be what and what and what.
Yes, but the law, for the law to dictate that, you need to say. Yes, but look at it. So now listen to this. What you're suggesting? Okay, give me a second. You're saying that if there is a woman with a scissors in her hand and she's going to try and stab somebody, then police are not the right people to send to her, but a nurse is a good idea to send to her.
Oh, we see that.
I mean, that's what you're trying to say.
That are trained specifically
trained
for that.
in what? Trained in what? A nurse is never going to be trained.
Controlling mentally ill persons.
A nurse is never going to be trained in dealing with somebody who's holding a scissor and going to stab someone. There's no way, there's no nursing training anywhere in the world which trains the nurses how to handle a woman with scissors in her hand which is going to stab somebody.
So then we're saying that the police will continue to encounter them and they will be hot.
But what I'm trying to say, the point I'm trying to say to you is that for certain instances, like this example that you gave, only a police officer will have to be involved with a nurse who's there to assist with them. In the kind of example that you gave, where it's completely inappropriate for the police to be involved in any which way. So the point I'm trying to make is that if you had very clear standard operating procedures to say which are the conditions when police will be involved, if the police are involved, how are the mental health professionals going to be there, when are they going to provide assistance, what kind of assistance will they be providing, and that is something that is agreed between the police system and the mental health system, and everyone is aware of it. That's what you probably need, rather than saying, well, take it away from me, because it can't be taken it away from you. You get what I mean? Like if there is a man who is holding a knife and saying, I'm going to stab someone, the fact that they had a mental health problem is actually irrelevant. You see what I mean? They are going to actually hurt somebody. So my simple point was that there will be instances when police involvement is necessary, and there will be lots of instances when police involvement is totally unnecessary. By having a very clear standard operating procedure, by having a very clear idea of how police and mental health services will work jointly, and then implementing that SOPs across the board is probably what will lead to a better outcome. You get what I'm trying to say is not, I'm not trying to say you do it all or they do it all. I'm trying to say there will be times you'll have to do it together. And when that has to be done together, having very clearly laid down procedures, who's going to do what, when is it not appropriate for you to be involved, when is it appropriate for you to be involved, are things that can be very clearly specified, is all I'm trying to say. Because otherwise you'll just have this kind of thing where things are getting bounced around and nobody gets any benefit out of it. Like the example of father calling you up and saying, my son's not taking medicines and he needs to be taken to the hospital. Clearly it's got nothing to do with the police. There should be a way by which police are able to easily hand it over to the mental health system and say, you need to respond to this. You understand what I mean? That's all. I wasn't at all trying to suggest that police should handle everything or should handle mental health issues. But police will have to handle violence or impending violence, whether it is by a person with a mental health problem or without a mental health problem. That's what you need to handle. You don't need to handle the mental illness. You need to handle the violence. You know, there's a distinction between the two. And when there is a mentally ill person without violence, you have no role at all.
But the thing about it is we are called for everything.
I totally agree. So
and
that's
that is
wrong.
what we don't want.
I totally agree with you, and I think that is wrong. I'm not disagreeing with you.
Yeah.
But I'm saying the way to solve that is going to be by having very clearly laid down boundaries of when the police should be called, when the police should be involved, when the police should not be involved, when the health system should deal with it. That's all I'm trying to get at. You know, I'm not trying to deny.
So I agree
that.
with you that in the new strategic policy direction, we should make the distinction.
Absolutely.
The public should be aware of it.
Absolutely.
And they should know when to call the police and when not to.
Absolutely.
But when not to call the police, they should know who to call.
Absolutely. And if they accidentally call the police,
and they should
you should know how to hand it over to the right person.
Because only the police answer the phone.
No. What I'm trying to say is that if you did get a random call which is inappropriate, then you should be able to pass it on to the right people. That's what is required. That's all I'm trying to get at.
Right. Now, earlier on, the mention was made of some of the jargons that have been used and how they should be revolutionized to reflect some other different kind of language. Now, presently, we heard about the urgency order. On that order, the word lunatic is there.
Written, I know.
So if you want to go to a new strategic direction, then some of that need to be revisited.
Well, you know, one of the things is that what we only presented to you was the policy at the moment, okay? And we have you in here to discuss the policy and what can be included in the policy. And what we discussed just now is great, because that what you talked about just now should be in the policy, you know, about when should police be involved, how should they be involved. But once we have the policy approved by the cabinet, one of the actions in the policy is to have a new mental health legislation. You know, the urgency order comes from the Mental Health Act, which is what, 130 years old. Okay. So there will be a new mental health law which will replace it. And the draft of that law is already something that we've been working on. So once the cabinet approves the policy, then the draft law will go to AG's office to be converted into a draft legislation. And at that stage, again, we would do a round of consultation with all the stakeholders, including law enforcement agencies. And yes, in that law, you would want to change all of that language will change from using words like lunatic and all will go away to using terms like persons with mental health conditions or persons with mental illness, you know, more neutral terms. Yeah.
Thank you. Afternoon, everyone. I would just like to add a comment to the discussion now and also to ask a question. As it relates to dealing with mental health patients, and the police intervention has resulted in many cases with incidents to patients who are mental health victims or mental health. and also to police officers. And we cannot negate the fact that we are the frontline persons, but also we may not be able to, because of our operational scope, have the capacity to deal with mental health patients. And therefore, I would strongly suggest that every response must have a mental health professional, not just a person who can respond with the police, but someone who can competently do a triage of that patient so that immediate steps can be taken. Because even if they show up, they may not be able to do anything immediately, and the transportation to the nearest facility may be 20 minutes or 30 minutes, and a lot can happen within that space of time. So I believe that that should be, apart from the SOPs that would govern what the police is supposed to do, what the unit is supposed to do, also spell out what happens step by step with that patient. So that's my comment. The question, and PS raised the awareness or a public session that will be happening. A lot of the families of patients, they normally call the police because they're more or less ignorant of how to deal with. What is in the policy or what is in the action plan to give families that type of autonomy to deal with their patients from the onset before it escalates and so forth? Thanks.
The first point is your first point was a comment which I agree with, so I don't think I need to. I mean, that's what we just discussed, and I totally agree with you on that. The second question, which is about the lack of knowledge, if I can put it, or the ignorance, if that's the right word for it, about what to do when somebody has a mental illness in the family and how should families react. I think that's what one is hoping, that through a national campaign of education and awareness building around mental illness, people will know, you'll get some changes in attitudes first. The second thing, that the education campaign also will have contents things like whom to contact, where to contact, what are the support services available. So it isn't just an educational campaign, but it's also an information campaign. If you have somebody who has a mental illness, what should I do? And if you need some information, where is the nearest hospital, which is a doctor I should go to, then it provides you with that. And that's the way that you want to actually educate the public to be better able to respond to mental health issues within their own families if it comes up, You want to add anything to this, Josh, about families and educating families how to respond to mental? Yeah.
Pleasant evening to all. For a very long time, we've had lots of conversation with the ministry that is responsible for mental health, or the section responsible for mental health, and there has always been a conversation. There is always the talk, and yet to see action or get the walk. However, I really hope that these consultations, these discussions bear fruits and it become very active, because as my colleagues already echoed and PS has said it also, too much of my colleagues have been hurt, harmed and injured by mental persons. I do understand our role and responsibility. Yes, I do understand when there is violence. That is what we are called for. However, we know that there are a lot of bureaucracies and the protocols that need to be administered or look into for action to take place. However, when the police is called, in those situations, we are also guided in terms of responding to reports that are made to us. And on that note, when we speak of diversing the mental health hospital or where they are held, and we're talking about community base, we must also understand and strongly tie these persons, these officers to their duty, because after 4 o'clock, I can't get a social worker. Difficult to get a nurse. Worse yet to get a doctor. Now picture Karakou, the Northern Division. You have to transfer or transport a mental patient via the ferry that is used by all other persons. We are also have our human resource challenges. Sometimes you have only one officer available, and I can't tell when he or she going to erupt. Want of a better phrase. And my safety is paramount. My staff's safety is paramount. So I say that to support the whole idea of the community-based institution or working mechanism, but the mental health personnel must do their job and be accountable. I'm happy for Sates, and it has been going on for some time, because I worked there in 2014 and it was already existing. But when 4 o'clock reach, who do I call when they call? No one to call. And there are times, even if you take them to the hospital, hello, the reality is it may take your entire shift, 8 to 4 shift or 4 to 12 shift, waiting for medical assessment. And on top of that, when you take them to the mental hospital as directed by the physician, you still have the runaround. You still have to wait at the institution to help them calm and settle down. I'm not trained for that. Additionally, the SOPs, I'm not too much in agreement for SOPs in that regard, and I'll say why. I want to suggest that those actions can be inscribed in such a way within the law. Just as how you have the Domestic Violence Act, you have the Child Protection and Adoption Act, you have the Juvenile Justice Act that tells the different stakeholders what to do, and it is part of the law. I think, speaking of mental health, that should be inscribed in that legislation or in that piece of act as opposed to an SOP. Because when Tom fail, what holds them? Yes, you'll tell me it's an SOP, you'll tell me it's a memorandum, but how much power and how far will it really go? Mental health can affect any one of us. We can walk out here this minute and then you realize, hey, well, Inspector Grant is way on the other side. Because it's real. Additionally, and I'm sticking to the Northern Division, which is Karakou and Pitimatnik, because it is really difficult for us when having to deal with a mental patient. Now, you have issues with mental patients. You don't see family members. After a call and you respond, that's it. In a lot of instances, not even the clothing, if you have to transport them or transfer them to Mongi. Now, you have the Osprey, which is 160, 180 to come across. That falls on the back of law enforcement fetching it. One may say, and I would put it early, is government, but at the end of the day, police have to source it for the moment to transport them. On the island, when you think of holding that person, you call the family members, it's not there. And on that, I would really like for not just to say, but if there is something in the law, just as how the Maintenance Act speaks to when the parent gets at a certain stage in their life, the children is responsible for their care and well-being. I would like to suggest also that when we're thinking of scribing the law, that there is a section that can bind family members into that care and well-being of their mental ill patient family. Finally, I want to beg of PS and our local team, the director, and the key persons that, as with every other consultation, not that we just sit here, we throw our ideas, we vent, and then we just see a piece of law that is not workable for our GPF. We would like that the final, or before it becomes final, that we are aware in sitting like this, because sometimes our seniors get the document, they give their sentiment, and how workable is it for us on the ground? Some of the legislations that we have these problems with, for example, the Juvenile Justice Act, a lot of things that is in it, it's hard for police officers to really work with it, because they're saying a sergeant have to, how much sergeants do we have beyond 4 o'clock to really do it when the call come in? So I'm just using that as an example, that when the law is being scribed, that those things are considered, so that it is not just a change to say we have it on paper or we went through that process, but it is a working process so that law enforcement would not have to pull the gun where they are, or someone's life is in imminent danger, but we have a one-stop shop with a community-based mental health institution, or bringing it back into the community where we can work together for the betterment, not just for mental health, but for all who come across them. Thank you.
Okay, so you spoke about the Child Protection Act, etc. Being in social development myself, the Child Protection Act, these SOPs that deals with the Child Protection Authority is also embedded in the Child Protection Act. So most time when you have SOPs are drafted based on the legislation that's there. So it's one speaking into the other. The SOPs must be in accordance with the legislation, right? And it cannot contradict itself. So when an SOP is established, it's established based on the laws that governs that particular organization. So you have the Child Protection Act, you have the Juvenile Justice Act, you have the Mental Health Act, and the SOPs that will be drafted to align how all the different bodies, stakeholders respond will be based on the legislation. So that is how it's done. So that is why we have the gender-based hotline that was in social development. Now we have in a hotline for suicide hotline. This is a whole of government issue that you are raising. The issue that you raise here is very salient, but it is a whole of government issue. I remember in the 1990s, we had to stagger things to allow persons. I don't know if some persons would have remembered the public officers on Friday used to leave, I think it was 5 o'clock, in order to accommodate late persons, because Friday the weekend was coming. And then certain ministries had to stagger in order for them to stop, ensure continuity of services, is that the public wanted to come to the business lunchtime, and we had to move towards everybody being at lunchtime, and we had staggered lunch. So this is an issue again, what you're speaking at. This was a whole of government issue. So what you're speaking to now is a whole of government issue. It's not just mental health or health, but this is something that must be tackled together as a whole of government, multi-sectorial response to what you are saying there. So this is something that is bigger than our ministry, and it must be treated at that level. Yeah.
All right. Good afternoon, everyone. I wanted to share my experience having dealt with a team from the Ministry of Health in the past. Now, what happened, I don't know what has happened over time, but I know what happened in the past during my time, of course. That has been some years ago. The ministry had a dedicated vehicle toward responding to mental health issues. So probably once a month, that would be field day. And so they would ask for an officer to accompany them from the station to visit the patients. I think what probably fell down, I don't know how well the records are kept of the status of the various patients. So there are some patients that you visit and they don't you just hand them the medication or your injection and they just simply take it wherever visit them at the home and so on. I know that worked. So I don't know if that has been a policy or it was just a practice, but I know that it worked well. So if it need to be embedded up, and that team comprised of the mental health workers, including a doctor. So if there is somebody that is out of right there, the order is signed and is easily transferred to the, so that happened in the past. And the vehicle is there, of course. I, as a police officer, accompany the team, and I've never touched anybody. The mental health workers, they would, if there is a need to restrain, they would physically restrain the person. But what I noticed though is that the level of training they had at the time. For instance, my observation, you go into a house where one is potentially violent, and what they would do, the team, one person would go at the kitchen where knives and things are stored and would block that area. One person would go at the sitting room and where there are things that so that level, I don't know if that level of training and expertise exists within the system. Because even though we build a system with policies and all of that, and there is not the personnel with that requisite training and skill that can function in that way. So that is an important aspect, that you have trained persons who form the team, and that sort of experience there. And it worked well there. So I don't know if that has fallen down. Based on what we observe in these days, that to me doesn't always exist. For instance, most of the time, the police vehicle, but they had a vehicle dedicated. So that has been my experience. So if we can get back there. Right. So if that approach that worked beautifully in the past with the team and the persons with the know-how on all of that can happen, and it happens smoothly. That has to, I don't know if it is written somewhere and it's not followed or what has happened, but that's just what I want to share.
All right, thank you, sir. So currently the community mental health team goes out beyond the monthly clinic days, and they actually give patients their medications, those who have been either non-compliant or for other reasons aren't able to attend the clinic. And what we have noticed is that fewer people right now are getting sick because they are on their routine medications. And so we've seen a significant reduction in the admissions as a result of that. So it is ongoing right now.
I went with some of the community mental with one pair of community mental health persons. What I understood is that 4 days of the week, they actually pay visits to people. Those were the rental. 1 day a week they would run a clinic where people come to see them.
Actually, they are going out in the community every day of the week except 1 day of the week, if you get what I mean. And they're going out and handing one back at the hospital when they come and run the clinic at the hospital. But 4 days in the community, they're actually going to people's homes. Like morning to evening, they'll go out and give the medicines. They'll see if they're well, if, just doing regular follow-ups in people's homes. So that is happening. It's not, and they do it on their own, as in they don't go in a vehicle. They just go as individuals.
Right, good afternoon again. Right, you hearing me? Yes, so I'm sure by from what you would have heard from all of my colleagues, it should become obviously clear, right, what the issue is. We could have this consultation. We could have the best put together draft bill that turns into legislation. If we don't have the stakeholders doing what they have to do to execute, then we're right back where we started. And the issue is, and we have to accept it, the reason why people are calling the police for any and everything concerning mental health issues is because they know that you call the police station any time of the day and a police officer will answer. Persons looking for help. And the truth is they cannot say that about the other agencies. And let us be factual about that. Right? Let us be factual about that. And there are some low-hanging fruits, for example, we could start with right now. Why should it take 6 and 8 hours in a health facility to get treatment for somebody who is obviously ill, mentally ill? I would think that you would want to treat them and get them out because they could disrupt your whole service. But even that does not seem to be a priority. I mean, you deal with an aggressive person, police officers in uniform, the person is aggressive, and you sit down in the hospital for 6, 8 hours. There is a reason why when you go to institutions like banks and so, they give priorities to certain people then. Because they understand that will make the productivity better. So I'm saying to us, unless we fix those things, we're right back where we started. Because we could say we have a mental health team. If you cannot have them, find them after 5 in the afternoon, then we're spinning top in mud, as we say in Grenada. And that is one of the biggest issues we're facing. As my colleagues like Mason and others were saying, that's why we get called for everything. When people want help, they want help. And they would call who they know is available.
Can I try and answer your question? Because I think that it's a relevant thing. And why do you think that happens? Why do you think you get nobody after 5 o'clock? And the reason for that is extremely simple, which is true not just for Grenada, but for everyone, for all of the countries in the Caribbean, okay? It is the lack of trained human resources. That is the real challenge that countries like Grenada are facing. You know, there are, for example, there are at least 4 Caribbean countries I know, including Antigua being one because it's close by, where they do not have a single psychiatrist on the island. They have repeatedly advertised for a psychiatrist and not got anybody. They've offered to pay double the going rate and still not got a psychiatrist. The point I'm trying to make is that, now you say that's not my problem. Fair enough, it's not your problem. But you need to also understand the reality in which the mental health services in countries like Grenada are operating under, which is a total lack of trained human resources. Nurses who get trained and become psychiatric nurses, many of them migrate off to Canada or US. You don't have. So the challenge really in running a mental health service is not that nobody understands the problem or does not want to do it, but it is the challenge of resources, and human resources being one of the biggest challenges, and financial resources being the second biggest challenge. But the primary challenge is having adequately trained human resources available to be able to actually run that service. You know, even today, Grenada has what? Two psychiatrists, 2 consultant psychiatrists, and that's it. That's all you have. And so if one of them goes on leave, because they will go on annual leave, you can imagine what the other one is going to end up having to do. They're doing 2 people's job. So the challenge really is not that people are unaware of what the problems are or that they are unwilling to solve them. The challenge is that even if you're willing to solve them, getting those human resources trained is a challenge. And so what mental health services across the country, across the world are trying to do in this situation is what we call task sharing. Okay, the term for it is task sharing. So like, for example, you say, listen, here are things that need to be done. For example, can school teachers do some of the work that maybe if you had a school counselor, you could do it? You know, you start doing the simple task sharing stuff with other resources that are available, because otherwise you have nothing at all. And that's really the way to, and that's where the concept of having SOPs, working in collaboration with police as opposed to working in opposition with the police is coming from. That look, there are things that we could be doing together and doing better, acknowledging that there are huge resource constraints that you face as well as the mental health services face. And I think that's probably the spirit in which we will have to go about trying to address the deficiencies that exist. There are obvious deficiencies. I don't think anyone's going to say it doesn't exist. Yeah. Oh, there are online folks? Who's there? Yeah. Hi. Can you hear us, Doctor? I think he's joined. Dr. Boat, you want to speak? Can he hear us? Yeah? While we sort that out, somebody else. Yeah.
Yes, good afternoon, everyone. We are hearing a lot about training and equipping personnel to deal with mentally ill patients, right? I am wondering if there is a strategy other than what we are using now that can be employed to have patients being recovered from the issues. And Monge Hospital is just maybe to have them at the stage where, take them at the stage where they are maybe cooled down by medication, and after just released back into the community. We see a lot of those patients walking the streets, sometimes untidy, like you use the word abandoned. And I am wondering if there can be an institution for further care rather than just Monge Hospital. After the release from there, can there be another place rather than the home, because families are not trained, in other words, to deal with the issue. And based on the behavior, some of the families are scared, so they don't care about them. Is there a place whereby, as to how we want to train people to take care of them, can we have a place where they themselves can be educated as to how to go about, or you assisting them in recovering from that issue, and they are brought into that stage where they are safe enough to be released into the society and be integrated again, and to go back to their families and live maybe nearly a normal life?
Well, I mean, the short answer to your question is yes, and that is what the policy is talking about. The short answer to your question is yes, and that is what the policy is talking about, which is to create a range of services which are available in the community, you know, supported housing, rehabilitation homes, ambulatory treatment where people are actually supported within their families, providing support to families. So what you need is a range of services. One size does not fit all. Different people will need different things or different kinds of services at different points in their illness. So there might be a point in the illness when they need to be in Monge for a couple of weeks. There would be a time when they need to go into a rehabilitation home, and there will be a point when they need to go back to their own homes. And so people will need a range of services which need to be there, which can then be utilized. And the policy does talk about having that range of services, because otherwise, as you said correctly, it's either Monge or bust kind of a thing. You know, you get nothing, you're on the street, which doesn't help anybody at all. Yeah. Hi, who? Oh, Dr. Bohat, go ahead. You can speak now. Well, okay.
Yes, good afternoon. Apart from Monge, I guess the prison has the highest accumulation of mentally challenged persons in Grenada. Sometimes I believe we actually work in Monge as officers, because currently we treat a high number of diagnosed patients, and a lot of them goes undiagnosed in the prison, and the prison is a revolving door. If 10 mentally challenged persons come today, 10 going back out into society. As it currently stands, we only have one social worker and one counselor. It's
it's not adequate to actually deal with the levels of mentally challenged persons. And we have 2 nurses currently at the prison. Yeah, one of the officers is actually trained to deal with mentally challenged persons. However, we don't really have the resources at the prison to really deal with those persons. My colleague said the police shouldn't really be the focus of the training to deal with them, but we don't have a choice. We have to deal with them on a daily basis. I don't think we ever had training to deal with mentally challenged persons at the prison. We deal with them how we can. Sometimes it's not the ideal method of dealing with them, but we have to do what we have to do to protect not only us, but other inmates at the prison. And I say all that to say is that oftentimes the prison is never included in any discussion on mental health and dealing with persons with mental health. Remember, all the persons we have at the prison now could be as much as 100, maybe more, with mental issues, will return back into society. They will. And the police will have to deal with them again. And they will come back into the prison, and sometimes, every time they come to prison and they go, it was than they were before. Prison have a tendency of making people crazy.
I just I just wanted to say to you that it's not true that the prison service is not included. Let me tell you that 2 months ago? 2 months ago, we had a similar consultation only with prison service officers, and there were close to around 15 to 16 people in the room, 20 people in the room, and it was a consultation only with the prison service. In fact, so it's not true that prisons are not consulted. In fact, we had and they brought up the same issue about the need for training, about the need to be able to handle people with mental health issues when they are in prison. So we are aware of those issues that did come up, and that it was about 2 months ago. It was not in this hotel. It was at the stadium. You know yeah.
So another issue is the fact that the prison can't do it alone. We need collaboration with other stakeholders, the Ministry of Mental Health, Social Services, because a lot of those mentally challenged persons, when they leave prison, they don't have anywhere to go. It's back on the street. Their family don't want them. Even though we try to reach out to families, they don't want nothing to do with them. We don't have a choice. If it was left to some of them, they would have stayed in prison. And some of them do want to remain in prison. But we have to shoot them out the gate, go, and we send them back on the street. So we need collaboration, because at the end of the day, our job basically finishes when their sentence is up. So we send them out into society, and that's it with us. And we know some of them, because of their mental issues, in the next month, 2 months, 3 months, they're back in prison. And it's the country resources we using to house them and feed them and so on. So it costs a lot to actually feed and house an inmate every day. 3 square meals and everything that goes along with it. So we need a lot more involvement, consultation, and the policies and legislations. It should include the prison and the services that the prison offers. Thank you.
Thank you. Thank you.
So prison made a very important point. What you're speaking about is a forensic ward at the prison. Persons who are mentally not stable, committed a crime, and they're there for a period of time. Now, that requires persons who are properly trained and can manage the ward. As you know, Grenada is experiencing a real hemorrhaging of nursing now. And this requires qualified trained persons. Very sad because we already identify it as a weakness within the system. We at the Ministry of Mental Health, however, we carry on, I think is once a month or twice a month, we have clinics. So our professionals will go up there and do our clinic once a month. Once a month we come and we do our assessments, and I think we have 2 staff up there that usually provide some level of care. But the ideal is to have a properly well outfitted forensic ward that is able to really treat and give the persons that proper care at that level. And it puts an extra strain on the prison officials, the junior and the senior prison officers and other personnel there to provide, which is really not ideal. One of the attorney had spoken out some time about it, and I noted his point is really on par. So this is something that we at the Ministry of Mental Health need to maybe have more further discussion. And that will entail maybe having proper study tour to see the success of other countries that were able to have such level of forensic ward, to determine what is the best practice for us here in Grenada, to determine the best fit that could accommodate such system within the mental institution. So again, are we glad that we have power with us here, and our experts could guide us properly to really see how we can really address this issue. And this has been a long issue with the prison, that I think not just building prisons, but having proper response. And I think this policy should really even delve into seeing how this should be addressed also. You know, so I think I take your point very seriously. Thank you.
Yeah, I also want to thank you for your point. It's important to note that we're meeting with the police officers and the prison officers today. We've already met with Ministry of Education. We met with Youth and Sport. We also met with Health, Social Development, Mental Health. And why are we doing this? Because everyone has a piece of this pie, so to speak, right? No, you are only interacting with the guys at the prison for a period, and it's not a very static population, because they're not going to remain in the prison to be treated. As you rightly said, sir, when the sentence is done, you have to release them. After you release them, what support is there for them upon release? So what are the social needs that they may have that someone else would have to step in and take care of? And you know what's interesting? Whether there's a mental illness or not, you do see guys who come and go. And you're seeing that because some guys come, they don't have a mental illness, but they go outside, they have no social support, they have no place to stay, therefore they get involved in crime again. So the whole of government approach would ensure that wherever we interact with people, we play our part. That is why we're really pressing that it's not one ministry's responsibility, but wherever we interact with the person, we play our part to the best of our ability. And this policy really strives to bring everyone together, so we have a concerted approach to dealing with this issue. Thanks again for your contribution.
Yeah, thank you. I was just going to read out what Dr. Burkhardt, who's a psychiatrist, wrote there in the chat. Yes, there is a need for a forensic ward. Once a month, I think he means once a month they visit. The ward would be able to nurse approximately 35 people. The ward needs specially trained nurses and psychiatrists as well as security personnel. So there is the idea of having a mental health wing within the prison, if you know what I mean, to deal with that. But I just wanted to thank you for a very important point that you Yeah, I will. What you made, which I think needs to be acknowledged, that you talked about collaboration and the need to work collaboratively. And I think I don't know if you noticed in the presentation that Jasmine did, there was an entire emphasis on intersectoral collaboration. You know, the idea that different sectors need to collaborate and come together to deal with the issue of people with mental health conditions. And it's not, not everything that is required for people with mental illness or mental health problems can be done by Ministry of Health. There will be other ministries and other sectors which also have a role. And the idea is, how do you get everybody to work collaboratively enough to get the best possible outcomes, given that you are also working in a resource constrained situation. Okay, and I'm not trying to say that you have a lot of resources and Ministry of Mental Health doesn't have resources, but that there is a resource constraint that all of the ministries face here. So I think that's really an important thing, that if we can get people to work in a collaborative manner and get different sectors to collaborate and work together, is probably the best way forward in this. Josh tells me that we should take a short break after this, but there was a question. Can we take that question and then we take the break?
Good afternoon, one and all. I have two suggestions. Due to the constraint that we are undergoing within the RGPF, constraint for manpower and transportation, I would like to see that at least 2 or 3 days designated so we can convey people with mental illness to Mongi. Because currently, it's only on Thursdays. We normally bring them straight to Mongi instead of bringing them to the hospital for a psychiatric evaluation before they be admitted to Mongi. So if we could have at least 2 days per week. And secondly, I would like to see that the Ministry of Health and other organizations sensitize the public more, have more radio program to educate the public on mental health and mental illness. That will bring the community together. You see, if the community continue to bash persons with that illness, it rather stigmatize. It make them feel shame. No one care for me. So we, the police, the community, everybody have to work wholeheartedly to see how best we could solve and help the people that has mental illness. So that's just my 2 suggestions. More radio programs, television programs, even in schools. You could have little seminar, little sessions in school. Thank you.
Break.
Okay, we take a 10 minutes break. So we'll get back here at 3:15.
Mike, if anyone wants a comment or a question or a suggestion, then please feel free to ask for the mic. Well, Josh is Josh.
Experience that I encountered.
Is the mic on? Just
is it? After everyone, well, everybody know who I am. Dealing with violent mental patients is very challenging. You know, some time ago, I'll give an experience. One of our officers went to deal with a mental patient, and he got gunned down. Yeah. And this kind of affected me a bit, you know. I feel emotional as I speak because he said that I think he called his wife and told his wife that he's gonna see her just now, and he didn't reach home yet. You know, I feel a bit shaky as I say that, you know. I feel a bit emotional. You know, telling your wife you're gonna see her just now, and then you didn't reach home yet. That's Edgar. You know, and the folks just turned their back on him. It's sad. And you know, he was killed with one of the most deadliest assault weapons, the AK-47, in the mountain in Victoria, yeah? I just give you a little experience, you know, it's nice to talk. Some time ago, I live in Montclair, and some time ago, I was at home, right? And a gentleman, I was off. A gentleman came to see me, he said, Charlo, boy, a madman giving some problem on the next side, boy, come and save your life now. Boy, you know, I like to help her. I jumped in the vehicle and I went. I went to my bag, I was making a little turn. When I touched down, as soon as I touched down by madman, I had to throw my bag and run, you know. Yeah, I could have dealt with him one time. I don't know who I am. I threw the bag and I run down, I run. And then I called for assistance in Sates, you know. And officers came to assist. That time the whole community under lockdown. Everybody inside, because the gentleman said he could take out a head today. And you know, in my book, I cannot afford for people here to come out. You know, the gentleman decided he go kill somebody today. Everybody locked down in Montclair. You know, and when I called for help now, a gentleman came to help me, a police officer. And we start to operate, you know. Madman, mad. He said, Charlo, I'm taking out your head today. Because I from Montclair and the gentleman from Montclair. He said, Charlo, your head coming out today. I said, not my head. But the man attacked us, you know. The man attacked my man, my police officer, back and the man come with the cutlass. And I can't stand there and let my colleague drop. We act on the man dying. And it still affecting me because as the police officer involved, I from the community, and when time for counseling, years to get counsel. You know, and it affect me. It's tough on us, you know. It's tough on us as police officers. It's tough. You know, I just like to speak so you're gonna feel our pain. You know, I say not to bash anybody because everybody in the same boat, you know. I don't want you to feel our pain, but at the same time, our lives is important. The mental man life is important, and it's sad. You know, if we didn't act, a police officer would have died on that day. And we act and the man died, and it affected me as we speak. Because when time for counseling is years. It take a whole year before I take a counseling, you know, and it affected me as we speak. So I hope better things would happen in the future. I ain't saying that to bash anybody. It's tough on us as police officers. It's tough on us as police officers. And as I say, our life is important. It's sad to know that the man died because, you know, in that community everybody knew me and people see me as criminal. You understand me? So they see me as criminal shortly after. Let me tell you what happened. I like to speak. Shortly after in Montclair, 3 people escaped and the whole community under lockdown again. We had to go and kill. We killed 3 of them. So they see me as the savior now, so you cannot turn around. We flattened them pitbull because they listen, we got a call, right? We came from an operation, I was sleeping, my boots in my foot, and somebody called and said, Charlo, look, pitbull eating a guy in Montcraven. Well, you know me already, I flash, I get my man and we hit. When we touch on there, I made the pitbull dragging the man. The man said, Charlo, oh God, by save my life now. Well, we eat them up, we kill them, we flatten them pitbull. So we come as a savior, you know. Well, it's someone to say, but it's nice. It's like a forum that's been nice to speak. You know, we express our experience, so we go make it thing better in the future, So our life is important, not because a man was mentally ill, be killing, but because one of my fellow men' life was in danger. I can't let the man go, the man and wife and children. So both of us pull triggers, and as you see that, we were taught to train, we were taught to shoot at the top. In our training, when we go in the range, we are taught to shoot at the top, not foot. So they say we need a team from the mental institution to handle mental patients. We could be involved also, but I think the health should take the lead. We should be there as the security. You understand me? So I ain't saying not to bash anybody, but let me make it think better because all life matters. Yeah, thank you.
Thank you. Thank you for honestly. Thank you for saying that. What you just said, and I'm glad you felt comfortable enough to speak your own personal instances. I'm quite happy that you felt comfortable enough to talk about it. But I think you highlighted one important issue which always gets buried under the carpet, is that there are huge mental health needs that law enforcement officers have for themselves. And those mental health needs are frequently not addressed. They're not addressed for various reasons. One particular reason which I can tell you is because even if you wanted to address them, law enforcement officers do not want to be saying, I have a mental health problem, because of the image that you have as a law enforcement officer. And that having a mental health problem or acknowledging a personal mental health problem is then seen as weakness of some kind. And this happens not just with law enforcement professionals, it happens with the army, for example. Armies across the world. The US Army had the highest suicide rate among all professions in the US for the longest time, largely because soldiers do not want to be seen as, I'm not going to go and talk to a counselor if I have a mental health problem. And so, one of the things that the police force can do is to actually work with the Ministry of Mental Health to see how active mental health support can be provided to law enforcement personnel, and especially debriefing for law enforcement personnel after traumatic events, that's very necessary, because if you're not getting the debrief, you're going to be carrying that with you and it's affecting your life physically and mentally for the next 10, 15, 20 years. It's affecting your family life, it's affecting your physical health. Having that provision is very important. And I think that's one of the reasons why the need for law enforcement and mental health to work together and in a collaborative manner. This is something that we did in Belize, which is we actually helped help them set up how could we provide mental health support to the police force, and also teaching the police force some self-help skills, the kind of things you can do to better look after your mental health, to be able to better take care of your mental health. There are skills that you can learn and you can help yourself to. So I think a close collaborative working relationship between law enforcement and mental health will benefit everybody, including the law enforcement personnel. This is not about the mentally ill people. This is about you as as professionals who work in situations which puts you at a high risk for mental health issues. So I just wanted to say that, look, I really want to encourage, thank you so much, because you raised a very important issue.
Good afternoon. I want to say that I look forward to the draft policy, and I heard the word collaboration mentioned for maybe 5-6 times, and it's very important. However, I do believe that we have to work on a baseline, and from that baseline, we will determine whether or not the policy that we are implementing is working. And I do hope that this policy, when we discuss it, we will see that there are timelines that we can review it as it relates to the working strategy of all stakeholders involved. This is my contribution.
Okay, so with respect to my good colleague here, we at the ministry notes that at times our police officers need some support too. You need some wellness time. You know, many times persons been going and not really having a time for self-care. And this is what we've been working out to build out a wellness profile for our ministry, whereby we can meet with some of you who are frontline respondents. And it can at times really traumatize. In fact, I could recall being in the court myself and having somebody passed away in the court, and you being the administrator there. It still linger in your mind, and you always will see that person on the floor pass away in the court. So sometime within your professional life, there's a lot of professional emotional times that you of yourself cannot get over on your own, and you need some time help to see you through. Also, it is key as you being managers, able to look at your staff and see who needs help. I remember before we had the employee assistance program, which was run by Mr. Hector, and at the time, we will recommend different things to assist our staff. Remember, we are human. We are not machines, you know. And we have our work life, we have our private life, we have family life, and we have a lot grappling with. We're trying to serve our citizens to the best of our ability. So at times, we sometimes tell ourselves, you know, that we're all right, and we may get through this through prayers and all of that. But sometimes the ministry, recognize that we must able to respond and support our staff. And in our collaboration and deliberations, your department was right down on top of the list, the police. And we also had the Supreme Court Registry, Mr. Hector, because in speaking to the registrar, she told us that she has so many of the staff that need support from us, because what is happening after being years within one area, having to read all those case files. I remember being in the court and you're reading all the case file and all the graphics, and sometimes when you go home, you don't want to sleep. In fact, sometimes when you go home, you check your door lock about 9 times to make sure it really lock. You know, because after the day's work, you always see yourself, that could happen to you, this could happen to you. So I'm just saying that to say that we really want to flesh out a wellness agenda that could really impact your organization, the police, the courts, the High Supreme Court staff. Because really and truly, at times you are dealing with a lot of trauma, you know. You are on the spot dealing with a lot of trauma, a lot of pain, a lot of hurt. And these trauma could really impact you for life. And without the right support, you could have a positive outcome and a negative outcome. So it's always important to know that this is something that our ministry only started last year, the wellness part, to build out the wellness. The religious affairs was there before, but the wellness more taken more, and this is what the public officers really need. Some more support on the wellness aspect of your public life. And for years we've been doing everything with efficiency and not really thinking about that also. Prison is another area that really needs a good wellness support. In fact, about 3 weeks ago, 3 of my nurses got injured. One patient broke one nurse hand, one patient broke another foot, another patient, the same patient broke one nurse, one foot. So the nurses were there, and I was clamoring to say, listen, my nurses are working, one nurse with 40 patients. I need to have a wellness time. So I sent everybody to do spa, who went to the hotel, who did this, because you could see the strain on them. They needed a break. They needed a time. And sometimes your supervisors have to really reach to that point where they listen, my staff need to have a little spa, they need a massage, they need a day pass, they need something that they can go and really revive to get energy to come back to deal with what is there at hand. So we are the Ministry of Mental Health. My matron, I always try to diffuse a lot of the tense, because they are in a tense institution, you know, coming into face what's there. So But thank God, one of the nurses is back now. Her leg is kind of healed, and she's trying to move around. So that is what we at the ministry sometimes are faced with. Sometimes you do not know what this. You're watching the nurses, and they are faced with a lot of issues they are challenged with. I had tried working when I came into that ministry, and I realized the risk. There is a risk. The risk that you are, I had liaised with the union representative. I said, listen, the persons who interact here, we need to get a risk allowance, because things happen, and this risk allowance now, I try pushing it through my union representative. I heard it is with our union, and it's been deliberated so that they can have something that can, sometimes you go good with your shoes, your bag, and everything is torn apart. At the end of the day, you have to pocket whatever casualty you had. So this allowance will help buffer some of the risk, not all, but at least some level of compensation, right? And that is the angle that we take. But I just say that to say, sometimes you need a wellness check on yourself, right? And wellness to make sure that you could go ahead. Sometimes you need a break. Take 2 days, rest yourself, come back, and do something for yourself to make yourself. At the end of the day, you work, you get all the monies in your pockets, and you cannot enjoy it, And this is something that you have to look at. I myself, I've been doing that for 38 years, running, doing government work, working up, down, doing everything. And at the end of the time, you stop and you say, hey, when did I last take a check for myself? Everything I do is for others, family and church and everything. But it's very important to check on you. Check on you, Make yourself happy. Make yourself happy. Because I see a lot of our public officers, we finish, we retire, and we're not enjoying nothing. You only have to be running with a prescription. You have to be running with a clinic. You have to be running to a private doctor and all of these things. And this is what you have worked hard and you want to enjoy. When you reach 60, it's time for enjoyment. And you notice, I know some of the police officers, they go into security. Come on, put up your foot, go on the sand, tip your foot in the thing, take a walk, enjoy a drink. I say, what is this? And you're looking, sometimes it's not all about all the monies. You may have the thing, but most time you need to just put yourself first. You've been seeing about family all your 30s, 40 years in public service. So you need some time now for you. And put away. And I did that to myself recently. I said, no. I am going to put some time into me because the wellness part of me is important. Right? So I want us to think about that, and so that we could really enjoy when our retirement comes. Thank you.
Thank you, PS. Thank you. Yeah, please.
All right. The fact that stakeholder involvement is so important. Is there a mechanism where the stakeholders can be involved to ensure that these things that we are putting together, they are managed and they happen like a committee or anything? Is that was that ever entertained? Some mechanism to make sure that the policy works. All these things here.
Okay, so we have finished now this week we'll be finishing our internal stakeholders. So we have two legs on the consultation. We have internal stakeholders, we have external stakeholders. So today will be our final internal. From tomorrow, we start up our scheduling with our external stakeholders. We starting in St. Andrews tomorrow at 6:30. We'll be at the Cinema Deluxe. Then we come back in St. George's on Friday. Thursday is holiday. And then the consultants will schedule a next visit to Grenada and will continue to the external. Now, while we do that, we had a PR person that we asked for another PR to come in. We'll be doing awareness and engagement. As we speak now, we have Dr. Chaitan is in St. Andrews with a speaker, and he's going around to the whole of St. Andrews on a loudspeaker as we speak. So we're trying to beef up the awareness as much we could. We need to have all on board. And we know the pockets area. In fact, from our data, I would like to say here that the adolescent and the child mental health clinics, they are growing. I've been monitoring it. From 2025, it was 125. At the end of 2025, it's 300. And for this time, it is increasing. So this is something that we are monitoring. We have been looking at the two hotspot areas, St. Andrew and St. George's. And the schools in St. Andrew, I know who they are, and the school in St. George's, I know who they are. And this is something that we have been looking and monitoring, and we have strategized a program named Stronger Mind, Stronger School, because what we have noticed over the years is that when you hold a person that are mentally ill, you hold them at adult age. That time, the illness starts even from in the womb, and we have not identified it. The system has failed in that instead of looking at from baby to come to adulthood, you responding, most time is the adults you're going to get to know. Very most time they're at adulthood, and the system had failed them in that the earlier part, the childhood age and the adolescent time, we weren't able to pick it up, but the issues were there. And as we treat it differently, sometimes I say the child rude, not realizing that that person should have been really being treated and monitored, evaluated, and cared for. I guess a lot of that is because of the stigma too that associated, and the family don't want to be associated. You have somebody in your home that is not mentally stable, so they want to, make sure the community have them in high standing when you should really be bringing your child to get the proper care. So what we have in is a growing adolescent and child mental health clinic in Grenada that requires a holistic approach in trying to bring down the statistics and addressing the situation as is. I see St. Paul.
Yes, just to support what PS has said and to the question, I believe that the policy caters for a technical working group to which there would be stakeholders from all of the key sectors as part of ensuring that this policy, after approval, really is implemented and supported throughout. And the ministry would have gone one step ahead, and we are now in the process, together with PS Jeremiah, in putting together an advisory committee for mental health. And the advisory committee will comprise of different sectors. We have government and non-governmental agencies that would help to provide support and guidance to the Ministry of Health to ensure that all of the strategic activities that the ministry have undertaken to ensure that we improve mental health services is done in an effective manner. So I hope that this helped to answer your question, Officer.
Okay, if there is no further questions, then we'll try and bring this session. Oh, sorry, you've got a question.
Just before you do that, sir, in light of what PS just speak of in regards to our child and adolescent mental health issues that is growing, PS, for you at the moment, is there any prescribed protocol as to how those information get through the relevant authority? So as an officer, you get a call in the school of a child, or maybe the parent call of a child self-mutilating or suicidal ideations and their likes, because many a time when they run away because something pushes it. What's the protocol in regards to them getting the help, understanding that every household wants to get away from the stigma? So avoiding the stigma, but providing the help, realizing that the clinic, that grouping is increasing. What advice would you give?
Okay, so they have these school counselors that will make contact with our consultants. Our child, adolescent and child clinic is being run by a lone consultant, and she has a skill set to analyze really what level of illness that the person is at, and from there they will have a referral pathway. So from that, they will either have them attached to the clinic, they will continue with, we have counseling within the various ministries, we have youth, we have social development, and we have education. So our level is now at a psychiatric consultant level. So from the analysis, they will determine whether or not the referral pathway. So not everybody who might say the thing will go into the clinic. It's based on the investigation and the level of whatever determination of illness that the consultant will determine where. So we have a referral pathway, but the professionals is the one what will determine the course of action for that person. So I cannot determine you, neither the police. When they are being assessed by the relevant personnel, then they will assign the referral pathway for them.
So just a clarity in terms of follow-up. At present, as police officers, you get a call, whether it's from the school, the household, or wherever, of a child in those situations, whether it's the cutting or ingesting of whatever. We will take them to the hospital. They will get medically assessed. A trend that I observe that is growing, the physician would ask the parent, or in one occasion I noticed that they would have, even if they made the call to Grenada and they said that that child need to be warded and what should happen, the parent objected, not even for medication, not even to have them, well, I don't want to say institutionalized, but warded at the various hospitals. So that it stops there, because I've seen where from the hospital, the parent just take the child back. And the doctor would say they cannot force it, but you're seeing it's not a one-off call or not a one-off response. You're seeing multiple cuttings. From the cuttings, you would have go to ingesting and the likes. So given the response that you give, is it just there, or what next should happen?
So truthfully, legally, because the parent has guardianship, you cannot force. But what becomes very significant in this process is the need to educate parents. That's a major component of the policy. We have to ensure that we educate parents so that they normalize mental health concerns. The issue is that parents are stigmatizing. They're stigmatizing, they're ashamed, and their actions therefore put the children at further risk, negatively impacts their prognosis. And even the way we communicate with the parents as well, which came up with our session, it came up in our session with the Ministry of Education, finding ways to communicate with the parents so that it is least stigmatizing. So instead of just seeing a disorder or an illness, we are also instilling hope while we communicate so that they understand the benefit if they take their children through the process. The education of parents is paramount.
Just to add to what Josh just said, if you wanted to overrule the parent, you would have to effectively trigger child protection procedures. Okay, you would have to trigger the procedures to say that the parents are putting the child at risk. And so it's a matter of safety of the child, which means you have to trigger child protection and you get the child put into care. Now, the question is, do you really want to do that? And in most cases, you don't want to do that. And so that's why instead of trying to use, using a cannon to kind of target a rat kind of thing, it's much better to actually focus on educating the parents, as Josh said, and about having a relationship with the parents to get them to actually take the help. Because there's no other way you can overrule the parent other than to put the child into care by saying parents are they're not fit to be parents. That's what you'll have to do. Which is not something that you want to take lightly and do it just because, they're taking the child home and they should have kept them in the hospital. Any other question? Any last question? Okay. Thank you all so much for coming here. Thank you for a very lively and animated discussion. And I just want to leave you with this one thought, because it's something that I would want you to go back home and reflect on, to do with your own, with the mental health of police officers. It's not something that is sufficiently addressed. And one of the reasons it's not sufficiently addressed is because police officers themselves are unwilling to acknowledge that they might have mental health issues, and which then means that you carry that with you. Let me tell you that police officers across the world are some of the highest risk professions for, police officers have higher rates of hypertension, as in blood pressure, than regular population. Police officers across the world have higher rates of depression than the general population. Police officers across the world have higher rates of suicide as compared to the general population. And I think what happens is that you are in a profession which is under high strain, and not acknowledging the fact that you do need mental health support at times puts yourselves at risk, which I don't think you should do. So I would want you to reflect a little bit on that aspect of where mental health interacts with police officers' lives. Apart from your work, it also interacts with your own life. So I wanted you to think about it when you go home about that. I'm going to hand it over to Josh to close the session for today. Thank you so much. Thank you all for being here.
Thank you so much, men and women of the Royal Grenada Police Force. Once again, you tend to outdo all the groups with your interaction. It's just so very lively. So give yourselves a round of applause, please. Thank you for taking the time out of your busy schedule to being here with us today. Your points have been noted. Rest assured, your points have been noted, and you have contributed significantly to the development of the National Mental Health Policy. Before you leave, please note that there are some refreshments at the back.
It's not here as yet. It's coming.
They came kind of late, but
please wait for the
better late than never. You can refresh yourselves on the way out. Thank you once again from the Ministry of Mental.
There's some
yes,
coming.
Yes, refreshments just came in, right? So please refresh yourselves on the way out. Thank you very much. Inside. Here we go, the final round of refreshments. All right, thank you.